There we go. Okay, we're recording. So we're really happy to have Ashley Turk with us here this morning. She is a pharmacy resident. She is going to be talking to us about cardiac medications. You know, it's one of those high-risk medications, sometimes can be low frequency. So we really appreciate her coming and speaking to us about that today. And I'll let her introduce herself to you.
Hi everyone, good morning. Thank you, Jenny, for that introduction. Like she said, I'm one of the current PGY1 pharmacy residents here at Inova Alexandria. I'm on my ED rotation, so you may have seen me in the emergency room over the last 3 weeks. I worked at CVS and retail for 3 years prior, so this year has also been a big year of learning for me as well when it comes to IV medications and thinking more acutely versus chronic patients. But today we are going to talk about medications, specifically cardiac medications that we see in the emergency room, and then some overdose or toxicities that we could see so that we can be prepared for those. So for a disclosure statement, there is nothing to disclose and there are no conflicts of interest. So for our learning objectives this morning, so we want to obviously review these commonly seen or used medications in the emergency department. We want to be able to compare and contrast why we choose certain medications over others, specifically based on patient-specific factors and disease-specific concerns. We want to be able to identify common medications that are incompatible with one another. So think about that when we're administering these medications. And lastly, be able to describe and also recognize how to manage calcium channel blocker, beta blocker, and digoxin overdoses. So when looking at our common cardiac medications today, we're going to break them down by drug class. That's the easiest way to kind of look at these each individually. So we're going to look at beta blockers, ACE inhibitors, vasodilators, calcium channel blockers, and antiarrhythmics. So first, we're going to start with beta blockers. So just for completeness on this slide, this is for all the beta blockers we're going to talk about today. So contraindications, patients we do not want to use these medications in. So if a patient comes in with decompensated heart failure or with a heart failure exacerbation, we don't want to use beta blockers. That can actually make the exacerbation worse. Obviously, if a patient's in heart block or sinus bradycardia, we don't want to use beta blockers because they're specifically working on beta 1 in the heart and they're going to slow the heart rate even more. Also, if patients have a systolic blood pressure less than 100, we don't want to lower their blood pressure anymore. And then obviously, if they have a history of an allergy to a beta blocker. For monitoring, we of course want to monitor heart rate and blood pressure when we give these medications. And then a very common side effect that you'll see patients complain of is dizziness. So we want to monitor for that as well. And thankfully, with this drug class, we really don't have to worry about renal dose adjustments. So the first beta blocker we're going to talk about this morning is metoprolol tartrate. So I'm sure you guys have all seen this in practice. We also have metoprolol succinate, which is the ER formulation. So a lot of times patients will come in and they'll have been on that medication. But in the acute setting in the emergency department, we're going to use metoprolol tartrate, which is our immediate release formulation. So this medication mechanistically is a selective beta blocker. So when we say selective beta blocker, what we mean by that is it only works on beta 1 in the heart. So we'll see other drugs this morning that work on other beta receptors. But for metoprolol, it specifically is only going to work on beta 1. And that will determine which patients we want to use it in and which patients we don't want to use it in. But for indications, we typically see this in the acute MI setting. We'll use it to get the blood pressure down for hypertension, arrhythmias, and even chest pain. So the typical dosing, we usually give 5 milligrams IV push over 2 minutes, and we can repeat that at least every 5 minutes. So typically in the acute MI setting, we'll see that given for 3 doses. This is not a drug that we typically use in pregnancy, but we will talk about this today. So on each slide today, I also will have where this drug is located, so if you can quickly get to it. So metoprolol tartrate is in your guys' Omnicell, so you won't have to wait on pharmacy to send that to you. As you can see, the peak effect is about 20 minutes, and the half-life is 3 to 4 hours. And then on each slide today also, we're going to have a clinical pearl, or the one thing that you really want to take away or remember from this slide. So the clinical pearl for metoprolol tartrate is going to be that this is our drug of choice when a patient comes in with an acute MI. The second beta blocker we're going to talk about this morning is labetalol. So before metoprolol we said was selective, labetalol is non-selective. So it works not only on beta 1 and beta 2, it also works on alpha. So beta 1 is the heart, beta 2 is in the lungs. So if we have a patient with asthma or COPD, this isn't going to be our drug of choice because it can make it harder for them to breathe. It also works on alpha, which is in the vascular. By blocking alpha, we cause vasodilation, which can help bring the blood pressure down. So of course, we're going to use this for patients with high blood pressure. We typically will use it in stroke patients to try to get the blood pressure down. The dosing, we can give 10 to 20 milligrams over slow IV push over 2 minutes. And we can repeat that up to 80 milligrams every 10 minutes. So we can give that push, but then if the patient's needing lots of pushes, then we can move to a drip. So this is ordered as a titratable drip. It's usually started at 1 milligram per minute. And we can titrate that every 15 minutes with a max dose of 3 milligrams per minute. So with each drip that's ordered, there's typically a goal. So the goal listed here is less than 100 beats per minute or systolic less than 120, but the prescriber or the physician that day can change that. So depending on the patient in front of you, their goals may be different. And the prescribers can also put in when to contact them. So if they're maxing out at 3 milligrams per minute, they might want to be aware of that. But that's when they go to order it, they can alter that. So this is actually the drug of choice in pregnancy. So if we have a patient come in with eclampsia or preeclampsia, this is going to be our go-to drug. For precautions, we do have to worry about liver impairment. So we usually start about half the dose for those patients. And then again, like I said before, we don't really want to use this in patients with asthma or COPD because it does block beta 2 in the lungs. But in some cases, we do have to use it and we can just monitor the patient's breathing. This drug is also in your guys' Omnicell, but only as the vial, so for the pushes. But if we did move to a drip, that's going to come from main pharmacy. So we would tube that to you guys.
And Ashley, just to let you know, we do have some folks on the call that work for HealthFlex, just in case there might be a little bit of, with Omnicell versus pharmacy mixing.
Yes, so I'll try to remember that throughout. I presented some of this to HealthFlex, so I know a few of things they may not have in their Omnicell, but thank you for that reminder. So the peak effect is going to be about 5 to 15 minutes with a half-life of about 5 hours. So the clinical pearl for this slide specifically is this is going to be our first line go-to for stroke patients in order to get that blood pressure down. The last beta blocker we're going to talk about this morning is esmolol. So esmolol is also a selective beta blocker. So just again, like metoprolol, only working on beta 1, and it's also a class 2 antiarrhythmic. So we typically see this as the drug of choice for aortic dissection, but it can also be used for patients who have arrhythmias, high blood pressure, or in the acute MI setting. So one thing I want you to notice on this slide is it's weight-based dosing. So when patients come into the emergency department or into the HealthFlex, it's really important that we get an accurate weight as soon as possible, either using the bed scale or a standing scale, but a actual weight, not like a stated or estimated weight. And that's important for many reasons, but of course we don't want to overdose these patients and we don't want to underdose them. So we want to be able to get them to their target quickly and not have to kind of teeter-totter with the dosing. So with esmolol, we want to give a 500 microgram per kilogram IV push over 1 minute. This can be given as a push, but it also, you can bolus it from the bag. So you can change that rate on your IV pump. I asked specifically in the ED a nurse, and she said typically they bolus from the bag, but you can do IV push as well. So it kind of just, I guess, depends on what your practice is, where you practice. So after we give the bolus, it is ordered as a drip. It ranges from 0 to 300 micrograms per kilogram per minute. The starting rate is typically 50 or 100 micrograms per kilogram per minute, and we can titrate that by 50 micrograms per kilogram per minute every 5 minutes. So the max dose we will run the drip at is 300 micrograms. And of course, it has a goal heart rate. So here listed as less than 100. But I know specifically in aortic dissection, we might have a goal even lower. So in pregnancy, this is not our drug of choice. So far, the only drug we've talked about today that we would want to use is labetalol. For precautions, this drug is a vesicant, so we have to make sure that we use the proper needle or catheter placement prior to and during infusion. So you can see the onset is really quick, about 2 to 10 minutes, and the half-life is only about 9 minutes. So that's one thing that makes this a drug of choice, because it has a quick onset, but if we need to turn it off quickly, we can also do that as well. So for the clinical pearl, this is the drug of choice in aortic dissection. So we have a case question here this morning. I don't know if you guys want to speak up to answer the questions or just put it in the chat. It's up to you what you're most comfortable with. But for our first case question, we have a 62-year-old male who comes to the ED with a chief complaint of chest pain. He explains it feels like his chest is tearing. His past medical history includes hypertension, hyperlipidemia. He currently takes losartan 100 milligrams daily and atorvastatin 40 milligrams daily. For his vitals, his blood pressure is 175/99 and his heart rate is 85. The CT of the chest confirms the patient has aortic dissection. Which of the following medications would be first line to control this patient's blood pressure and heart rate? Good. Awesome. Thank y'all for replying in the chat. So Esmol is going to be our drug of choice for aortic dissection. So nitroglycerin would be more for chest pain, can be used for blood pressure. And allopurinol we haven't talked about this morning, but that's not the drug we would go to. And then amiodarone would be more for rate and rhythm control. So this is the same case, but the question is just true or false. Does esmolol require a bolus? True or false? Yes, so it is true. Esmolol does require a bolus. So if you remember, it's that 500 microgram per kilogram bolus. That's what we want to get before we start the drip. All right, so last question for this case. So, well, I kind of just gave you guys the answer. We'll see if you remember. So what is the dose and how quickly can you push esmolol, the bolus specifically? Good. So yes, so the correct answer is going to be B, which is the 500 microgram per kilogram IV push over 1 minute. All right, so the second drug class we're going to talk about this morning is ACE inhibitors, and we only have one, but from my memory, we do not have this at the health plexes. So if you're at health plex, you typically aren't going to see this drug being used because it's not available for you guys. So that drug's going to be enalaprilat. So it is an ACE inhibitor. So ACE inhibitors specifically work in our kidneys. They prevent the conversion of angiotensin 1 to angiotensin 2, which angiotensin 2 is a potent vasoconstrictor. So by blocking that, we will cause vasodilation, and which will lower the blood pressure. This drug can be given 1.25 milligrams over slow IV infusion over 5 minutes, and we give this drug every 6 hours. So most of the drugs we've looked at today, we've given more frequently. So this drug, we're not going to give back to back. We're just going to give that 1.25 milligrams every 6 hours. And then you can give up to 5 milligrams every 6 hours, but the initial starting would be 1.25. This is not a drug that we use in pregnancy. So ACEs, I typically in my mind group them together with ARBs. So like losartan, valsartan. Neither of those drug classes do we use in pregnancy. For contraindications, if you have a history of angioedema or hypersensitivity to either an ACE or an ARB, so if you have an allergic reaction to an ACE, you're really likely to probably have one to an ARB as well. So we typically avoid those in those patients, and we typically see this more in patients who are African American. Precautions, so renal dose adjustments are very important when it comes to ACE and ARBs. So we need to renal dose adjust if a patient's creatinine clearance is less than 30. I think it's important to remember a lot of times when patients come into the ED, they're not at their best health, and oftentimes they're in AKI. So this would be a drug that we wouldn't want to initially give. But in some circumstances, if their kidneys are fine and healthy, we can use this drug. But for monitoring, of course, we're going to want to monitor their serum creatinine, also their potassium levels. So naturally, when we give this drug, the serum creatinine goes up, and so do the potassium levels. So if a patient already has a high serum creatinine and potassium, this isn't a drug we would want to use. Obviously, we're going to monitor blood pressure for signs and symptoms of hypersensitivity. And then lastly, a cough. So you'll hear patients who take ACE inhibitors complain of cough a lot. And so oftentimes doctors will change them to an ARB, but the cough is only a symptom or an ADR of an ACE inhibitor. And that's just how it works mechanistically. So if the drug is controlling their blood pressure well, but they're tired of the cough, we can just change those patients to ARBs. This drug is not at HealthPlex, and it's actually not even in the Omnicells here at Alex. So this will come from main pharmacy. The onset is about 15 minutes and the half-life is about 35 hours. So when you see that half-life is 35 hours, it kind of makes sense why we give it every 6 hours and not as frequently as some of the other drugs. So the clinical pearl for this medication is going to be to remember it does require renal dose adjustments when that creatinine clearance is less than 30, and we need to monitor potassium levels. All right, so for knowledge check, which of the following patients would we not want to administer enalaprilab to? A patient with heart failure, B, a patient with a drug allergy to hydralazine, a patient who hasn't been to dialysis in over a week, or D, a patient with hyperlipidemia. All right. Good. So it's going to be that patient who's missed dialysis for a week. So likely their potassium is very high and their serum creatinine is probably most likely very elevated. We typically don't use ACEs or ARBs in dialysis patients, but sometimes we do use them at low doses. But choice A would not be right. We can use ACEs or ARBs in chronic heart failure patients. It's actually part of the GDMT therapy. We want to use those drugs. If you had an allergy to hydralazine, that doesn't really matter. And then if you have high cholesterol, it doesn't really apply either. So yes, choice C. The next drug class we're going to talk about is vasodilators. So the first drug we're going to talk about is hydralazine, specifically when we give it as a push. So its mechanism of action is pretty simple. It's a direct vasodilator. So again, vasodilation causes the blood pressure to come down. For dosing, we can give it as a 20 milligram IV push, and we can repeat that every 4 to 6 hours as needed. So this is the second drug today that we're looking at that can be used in pregnancy. So we've seen labetalol and now hydralazine. We don't want to use this in patients who have mitral valvular rheumatic heart disease because it can increase the pulmonary artery pressure. Of course, we're going to monitor blood pressure, and this is in your guys' Omnicell. The onset is about 10 to 80 minutes. It's very variable, so that's often why it's not our first go-to drug of choice, because depending on the patient, they might not respond very quickly. It could take some time. And then the half-life is 3 to 7 hours. The clinical pearl for this slide is going to be that it's incompatible with magnesium. So a lot of times we'll see patients come in with low electrolytes, and they could have high blood pressure. So we just need to remember that these two drugs cannot be given at the same time. The second vasodilator we're going to talk about this morning is nitroglycerin, specifically as a drip. So its mechanism of action is it's also a vasodilator, but it also works on the veins and the arteries, and I like to think of it more as a potent vasodilator. It's often used for patients who have chest pain, acute MI, heart failure, acute decompensated, and then hypertension, of course. So it can be ordered as just like a standard flat rate drip, which is going to be the 20 mics per minute, or it can be ordered as a titratable drip at 0 to 100 micrograms per minute or 0 to 400 micrograms per minute. So we typically start at that 20 mics. We can titrate by 10 mics per minute, and we can titrate every 5 minutes specifically, but the max dose is going to be 400 mics per minute. And this is not a drug that we use in pregnancy. So something really important to remember with this drug class is that we cannot use it with PDE5 inhibitors. So what are those? So you've got sildenafil, which is Viagra, which we're all very familiar with, and tadalafil, which is Cialis, but tadalafil is now generic, so you might see that more. And then vardenafil, I rarely see that one. But it's important when the patients come in and we're doing their med recs to ask if they're on these medications. A lot of times they don't want to obviously say because they're embarrassed, or they'll say it's for some other indication, but it doesn't really matter. It's just, are you on it or not? And tell them the risks that it can cause, like life-threatening hypotension. So we want to, of course, make sure we're getting good med recs, but also tell them the risks. So hopefully that they'll be open and honest with us. So for precautions, so most of the drips we don't have to titrate. It's very important with this drip when we're wanting to DC it and the patient's tolerating it that we titrate it down. So we need to lower the dose by 5 to 10 micrograms every 5 minutes. Also, nitroglycerin is incompatible with furosemide and metoprolol. I think that's very important because we can use this in patients with heart failure. So we're probably going to be given Lasix, or we're going to be using metoprolol. We could be using all of these drugs together. So it's important to remember that they cannot be given at the same time. This is in your guys' Omnicell. The onset is very quick. It's actually immediate, and the half-life is only 3 minutes. So it's in and it's out very quickly. The clinical pearl for nitroglycerin is that we have to use a vented spike. So for our knowledge check, hydralazine is incompatible with which of the following medications? A, cefepime, B, potassium, C, magnesium, or D, Zosyn. Good. So C, magnesium is correct. All right. So true or false, nitroglycerin requires a vented spike. Good. So everyone's saying true. All right. So the next drug class we're going to talk about today is calcium channel blockers. So the first one we're going to talk about is nicardipine. So calcium channel blockers in general, there's two different types. So we have DHP and non-DHP. So nicardipine is a DHP, and basically what that means is it's mostly working on the vascular, whereas what we'll see with diltalsym, it's non-DHP and it's working on the vascular and the heart. So we typically use it for to help control heart rate. But for nicardipine, it's DHP, it's just working on the vascular, so it's going to help with vasodilation to lower the blood pressure. For its indication, obviously it's used for hypertension, but this is often a drug we use for stroke patients. So after we give alteplase, we typically will use, or before we use alteplase or after, we will use nicardipine to get that blood pressure down. So it is ordered as a titratable drip from 0 to 15 milligrams per hour. We typically start at 5 milligrams per hour, and we can titrate by 2.5 milligrams. We can titrate as frequently as every 5 minutes. and the max dose is going to be 15 milligrams per hour. And this drug can be used in pregnancy. So we've got labetalol, hydralazine, and now nicardipine that we can use in our pregnant patients. For contraindications, we don't want to use this in patients with advanced aortic stenosis, and that kind of goes along with precautions. Reflex tachycardia can occur, resulting in chest pain or an MI in patients who have some obstruction and coronary disease when a beta blocker is not on board. The half-life of nicardipine is about 14 hours, and the onset is about 45 minutes until takes about 45 minutes to reach half of the effect. And this is in your guys' Omnicell. It wasn't always routinely in the Omnicell, but it is now. For the clinical Pearl, this is the drug of choice of patients who are in hypertensive emergency and we need to get the blood pressure down, but they're in some form of acute renal failure. So we don't have to renal dose adjust. The second calcium channel blocker we have this morning is diltalsum. So again, this one is non-DHP. So we're working on the heart, specifically with depolarization, so affecting the rhythm, and then also in the vascular, lowering the blood pressure. So we typically see this in patients who have arrhythmias, chest pain, or high blood pressure. The important thing to remember about diltalsum is we do weight-based dosing for it. So we've looked at several drugs this morning, but the only two that we've seen weight-based dosing with is esmolol and now diltalsum. So the first IV push is going to be 0.25 milligrams per kilogram IV push over 2 minutes, which is going to be a range of about 10 to 20. And then if the patient's not responding in 15 minutes, we can repeat that at a higher dose of 0.35 mg per kg IV push over 2 minutes. And that range is 20 to 25 milligrams. After the IV pushes, we can then start a drip, which ranges from 0 to 15. We usually start anywhere between 5 to 10 milligrams per hour. We can titrate that by 5 milligrams every 30 minutes with a max dose of 15 milligrams per hour. So you'll see the half-life is about 4 to 5 hours. So that's why we're not going to titrate it as frequently as some of the other drips. This is not a drug that we use in pregnancy. This is in your guys' Omnicell, both the vials and the drips, and they're both in the refrigerator. Just like to highlight that because sometimes in a moment of panic and you're looking for the green light on the Omnicell, you're like, where is it? Both of them are in the refrigerator. So for the clinical Pearl, it is incompatible with several medications, cefepime, procainamide, and sodium bicarb. So we have a case question. So a 29-year-old pregnant female comes to your emergency room complaining of leg swelling, and she states she feels dizzy with a headache that will not go away. Her blood pressure is 185 over 101, and her heart rate is 75. Which of the following medications is first line to control this patient's blood pressure? Good. So everyone's putting D in the chat box. So labetalol is going to be our drug of choice. So nitroglycerin, we do not use in pregnant patients. Diltalsum, we don't use in pregnant patients. And then again, enalaprilat, we do not use as well. So labetalol we would use. And then the other drugs we could also use would be hydralazine and nicardipine. All right, so we know that we're going to give labetalol to this patient. How should we give it to the patient for an IV push? All right, good. So lots of you are saying C. So we're going to give 10 to 20 milligrams over slow IV push over 2 minutes. All right, so no longer on the case, just a standard question. So how often can we titrate a nicardipine drip? All right, so it is going to be B, so every 5 minutes with a max dose of 15 milligrams per hour. Looks like we were a little hesitant with that one, but if it is ordered, it will be in the order. So if you're not sure, you can always refer back to that. I know numbers sometimes are hard to remember. All right, so the last drug class we're going to talk about this morning is antiarrhythmics. So the first one we're going to look at is digoxin. So to me personally, antiarrhythmics mechanism of actions are a little more complex. They're not as straightforward. But for digoxin and most antiarrhythmics, we're working on some type of electrolytes and working on the contractility of the heart. So this drug specifically works on sodium and potassium on the ATPase pump, which will increase contractility, but also cause suppression of the AB node, which will cause positive inotropic effects, which will increase the vagal tone and decrease the ventricular rate. So of course, we're going to use this for arrhythmias. We can also use it in heart failure patients. For dosing, it's going to be given as an IV push. It can be given undiluted or diluted, but the important thing to remember here is it's going to be slow IV push over a minimum of 5 minutes. The typical dose range is from 0.125 to 0.5 milligrams, and this is not a drug we use in pregnancy. There's also a contraindication if a patient is in VFib to use digoxin. Something just you want to keep in mind, it can be confusing, milligrams versus micrograms. Some people may use them interchangeably, but in EPIC, everything is in milligrams, but there have been drug errors due to that confusion with micrograms versus milligrams. There can be digoxin toxicity, so we also monitor patients' levels, which we can give Digifab if needed, and we'll talk about that later when we talk more about overdoses and toxicities. This is in your guys' Omnicell. The onset is very variable from 5 minutes to 60 minutes, but the half-life, as you can see, is very long for 2 days. So usually we're just giving this as a one-time dose. We can give multiple if we're loading a patient, but typically we're just going to see it as a one-time dose. For a clinical pearl, we want to avoid rapid IV infusion because this can result in systemic and coronary vasoconstriction. So that's why we want to give it slowly so we don't cause any extra vestation. The last antiarrhythmic we're going to talk about this morning is amiodarone. So this is specifically a class 3 antiarrhythmic. It works on sodium, potassium, and calcium, which will prolong that action potential, and refractory period, which will decrease the AV conduction and sinus node function. So we're going to use this obviously in arrhythmias. We typically see this with VTAC or VFib. So if we have a pulseless VTAC or VFib, we're going to give 300 milligrams IV push. And then we can give an additional 150 milligram bolus once. And then that's followed with a maintenance strip. But if the patient has a pulse, then we're going to start with that 150 milligrams. That can be given as an IV bolus drip, the premix, and that's given over 10 minutes. And then we'll give that maintenance strip. For the maintenance strip, we typically start at 1 milligram per minute over 6 hours. And then it'll go down to 0.5 milligrams per minute over 18 hours. This is not a drug that we use in pregnancy. It is important to remember if a patient has an allergy listed for iodine, this is not a drug that we want to use. We also don't want to use it if a patient's in sinus brady or heart block. It's going to lower the heart rate. For monitoring, I typically think of amiodarone as kind of a dirty drug. We typically do see elevations in liver enzymes, so we want to monitor that. We also want to monitor thyroid function. As if you remember in school, the thyroid absorbs iodine, and we can't use this in patients who have an allergy to iodine, so we need to make sure we monitor the patient's thyroid function, and then heart rate and blood pressure. The onset is very kind of slow within a few hours. And then you can see the half-life is very long, so 9 to 36 days from just one single IV dose. And both the bags and the vials are in your guys' Omnicells. So the clinical peril for amiodarone is going to be that it has a very, very long half-life, and it needs filtered tubing for drips. But for drips, when we say it needs filtered tubing, that's for the maintenance drips, not the drips that are given over 10 minutes. All right, so how should digoxin be given?
Ashley, I think you're on mute.
Thank you. Sorry, I didn't want y'all to hear me gulping water. So yes, so it's going to be slow IV push over 5 minutes. So we don't have any of that extravasation or try to avoid it. Amiodarone maintenance strips must have which of the following for administration? Do they need a port? Do they need a peripheral line? Do they need to be protected from light, or do they need filtered tubing? Good, so everyone is saying D, so yes, it is filtered tubing. All right, so just a little recap before we go into overdoses and toxicities. So kind of just think of like the scenario in front of you and then what the drug of choice would be. So if we have a patient with preeclampsia or eclampsia, we are going to give labetalol, hydralazine, or nicardipine. If a patient comes in with an acute MI, we're going to give esmolol, labetalol, nicardipine, or nitroglycerin. If we have a stroke patient, we are going to use labetalol or nicardipine to get that blood pressure down. If a patient's in VTAC, amiodarone would be our drug of choice. If a patient's having chest pain that's not responding to, say, sublingual nitroglycerin or a beta blocker, then we're going to start that nitro drip. If a patient's in hypertension emergency, we're going to start nicardipine or labetalol. If we have a patient come in with aortic dissection, we're going to use esmolol or labetalol to control that heart rate and blood pressure. If a patient comes in with hypertension but is also in acute renal failure, we want to use nicardipine. And then lastly, if we have a patient who's an AFib with RVR, we're going to use diltalsum. All right, so now we're going to kind of shift gears and talk about if some of these medications were taken inappropriately, either inappropriately on accident or on purpose. So the first drug classes we're going to talk about are calcium channel blockers and beta blocker overdoses. So in 2019, the American Association of Poison Control Centers did say there was about 6,000 single exposures to calcium channel blocker overdoses. There were 31 deaths and 111 major outcomes. And then about 1,000 patients were actually younger than the age of 6. So this can happen if a patient or a child gets a hold of their grandparents' medications, or it can be done intentionally for like suicidal purposes, or you could have an elderly patient that just accidentally took too many of the wrong medications. And the same can happen with beta blockers. And then I have some numbers there for you, but it's about the same as with calcium channel blockers. So these medications, specifically calcium channel blockers, are very highly protein bound and they're metabolized by the liver. So as we increase that dose, the clearance rate decreases. So the drug is staying in the body system for a lot longer. Majority of the beta blockers are metabolized by the liver as well, but a few are metabolized by the kidneys. But the important thing to note here is that deterioration can occur rapidly with both of these medications if a large amount is taken. So what does this look like? So for calcium and channel blockers and beta blockers, we're grouping them together because we basically treat them the same, but there's only a few key differences. So for both of them, we are going to see hypotension and we're going to see bradycardia with arrhythmias. So that makes sense. So both of these drug classes are going to lower blood pressure and lower the heart rate. So if you take a lot of it, those are the signs we're going to see. But specifically, when we look at calcium channel blockers, the patient may or may not be mentally altered. They could have signs of like heart failure with the jugular venous distension or pulmonary edema, but they are going to have hyperglycemia. Whereas in patients who overdose on beta blockers, they're going to have hypoglycemia. Also, they're most likely going to have mental status changes. They could have seizures. Their potassium is likely to be elevated, and then they could have bronchospasms. So if you remember earlier, we were talking about beta 1 and beta 2. So if someone took a bunch of labetalol, they could have bronchospasms because that, if you remember, it works on beta 1 and beta 2 and also alpha. But specifically with the trouble breathing, you're going to see that with lots of blockade of beta 2. So how do we treat this? So with most medications, if they've just ingested the medication, if it's been less than 1 hour, we can go the activated charcoal route. But if we don't know how long it's been, or if it's been greater than an hour, we're going to go this route. So initially, we want to fluid resuscitate these patients because they're hypotensive. We want to bring that pressure up with fluids. And then we're going to use atropine to get the heart rate up. So once we do this, and if they're not responding, then we're going to move to a more extensive regimen, and we'll break this down further. So thankfully, we have an order set here at Inova Alexandria that we can use to really help guide us for the prescribers, for the pharmacists, and for the nurses. So this is really nice to have. So if you'll remember initially, we want to do that fluid bolus to get the pressure up, and then the atropine to get the heart rate up. So what you guys need to remember is that this can be given every 3 minutes and max dose of 3 milligrams. So we'll also give a calcium bolus. So we use calcium because it also helps increase the blood pressure and cardiac output. The things that you guys want to remember is gluconate versus calcium chloride. So calcium gluconate, we can give for 3 doses. We can give 3 doses of calcium chloride, but calcium chloride can only be given through a central line. So that's really important. I think an easy way to remember it is like the 3 C's. So calcium, chloride, central, kind of keep them all together. And then once we do that, we can give glucagon as well, which is on the next slide. So glucagon, as you could see, it wasn't checked off initially, so the prescriber can choose yes or no if they want to order it. So you might not always see it, and you're typically more likely to see it with beta blocker toxicity because it's just been studied there a little further than with calcium channel blockers, but it's not wrong to use it in both. But specifically, you're going to give a bolus. It's going to be weight-based, but the max dose is 10. And you're going to give that every 5 minutes as needed. If the patient is responding well to the glucagon, then we're going to start a drip. So typically you're going to see an effect within 1 to 3 minutes, but after 10 minutes, if you've given 2 doses and the patient isn't responding to the glucagon, so we're not seeing an increase in heart rate, we're not seeing an increase in their pressure, then most likely starting a drip isn't really going to help. A common side effect that you may see in your patients once given glucagon is vomiting. So if you think about it, it's a lot of sugar going in and they're not going to feel too good. I had that done once to me and I was so nauseous. So the patient might complain of that. So once we've done the initial treatment, if the patient's still not responding, then we're going to go into our high dose insulin regimen. So this is a lot different than typically what we see of patients who come in, say, with DKA. It's very highly concentrated and it's a lot higher of a dose. So initially, we're going to give a bolus of 1 units per kilogram. So the patient that I was taking screenshots from on Epic, they were 94 kilograms. So we're literally going to give them 94 units for 1 dose. Once we give that, it's going to be followed by an insulin drip, which is also very concentrated. So 4,000 units in 250 mLs. So when we see patients who are in DKA, it's like 100 units per 100 mLs. And we're going at like 0.14, I believe, units per kilogram. So it's a lot lower. So usually we start about 0.5 units per kilogram per hour, and we can increase by that as well. And we'll titrate every 15 minutes. And here our goal is going to be to get that blood pressure greater than 90 for systolic and a heart rate greater than 50. So what you guys need to remember is that this is a high concentration and that you have to change your pump settings. So specifically on your pump, it'll say calcium channel blocker / beta blocker overdose, and you want to use that instead of the normal insulin infusion. So we're giving these patients all of this insulin. So what else do we need on board? So obviously we have to have a dextrose infusion running at the same time, or else the patient's going to go into hypoglycemia. So that will be ordered simultaneously with that insulin drip. And we're going to titrate to a goal between 140 to 250 for their blood sugar. And then it has parameters when you would need to contact the prescriber. It's also ordered with a bolus of dextrose that can be given if needed. Also with high dose insulin in general, if it's just like, even if it's for like DKA with the lower amount, you're typically going to see a drop in potassium. And that's because when we give insulin, the potassium levels will change intracellularly versus extracellularly. So we want to have that potassium on board, and that can be given as needed. And then lastly, of course, we want to monitor the patient's blood sugar very frequently. So if the high dose insulin regimen doesn't work, then we can move to fat emulsions, which apparently is very rarely used. But I would just want you guys to know that it is a thing and it could be ordered. And what you need to know is that it does need a 1.2 micron inline filter. All right, so for a case question, an 18-year-old male is brought to the ED by a friend after admitting to an attempted suicide. When asked what he ingested, he states he swallowed a handful of his grandmother's labetalol this morning. For past medical history, he has depression, anxiety, and asthma. His blood pressure is 80/50, his heart rate is 45, his blood glucose is 55, and his O2 stats are 80% on room air. So we've given this patient a fluid bolus, we've given him 3 doses of atropine, and he's still symptomatic. Which of the following regimens would you expect the MD to order? Give you guys a few minutes. Right, so good. So it's going to be B. So we're going to do IV regular insulin, 1 unit per kilogram bolus. And then you're going to see potassium ordered, you're going to see dextrose ordered, and then you're going to see that continuous infusion. So I want to highlight why the other answers are not right. So we do not want to use sub-Q. That's not going to work fast enough for the patients. And then we're not going to use lispro insulin, we're going to use regular insulin. Anytime we do IV insulin, it's regular. And then we're not going to repeat another dose of atropine or fluids. Once they fail that initially, we're going to move to the insulin route. All right, which of the following must be given through a central line? Good, so it is going to be D. So if you remember C, calcium chloride central. So gluconate can be given through either, and so can magnesium and potassium. All right, which of the following must be given if a patient is on that continuous insulin infusion? All right, good. So it looks like everyone's saying C, dextrose. So yes, absolutely. If we're pushing insulin in at this high rate, we obviously need to have dextrose running as well. The other answers aren't wrong. We'll typically be giving those as well, but you must have the dextrose on board. All right, which of the following are true regarding insulin therapy when treating patients with calcium channel blocker or beta blocker overdoses? I'll give you guys a few minutes to read this one. All right, perfect. So it looks like everyone's putting E in the chat box. So yes, we're going to give that bolus. Then we're going to start that infusion. We have to adjust those pump settings to specifically the calcium channel blocker and beta blocker overdose. So it's giving it at the correct rate. And then we have to have our dextrose and PRN potassium ordered as well. All right, so our last topic this morning, and I'll try to go through a little quicker since we're running out of time, is going to be digoxin toxicity. So in 2017, there was about 1,600 cases of digoxin toxicities in the US, and about 600 of these patients did suffer moderate to major toxicities. So digoxin is a very narrow therapeutic index drug. So basically what that means is if we just give them a little too much, the patient could become toxic. When we're ordering levels for this drug, it's really important, or when we're drawing the levels, to know when it was last taken. So it has to be more than 6 hours. So if it's less than 6 hours, then it could look high, but that's just because the drug hasn't had enough time to metabolize. For signs and symptoms, so this can be seen acutely or chronically. Acutely, you're going to see more of that nausea and vomiting and abdominal pain, but that can also still be seen chronically. And then for chronically, you're going to see more of a confusion, headache, drowsy patient. For acute, you'll see more bradycardia, and then with chronic, you'll see more tachycardia. With both patients, you'll see visual changes, but then for the digoxin levels, if it's acute, you're going to see a high level for sure, but if it's chronic, it could appear normal or it could be high. So who requires digoxin toxicity treatment? This is just listed here for your information, but basically patients who are very symptomatic. So the drug that we use for digoxin toxicity is Digifab. And we're going to dose that based on if it's chronic or acute, and if it's acute, more of unknown versus a known. So this is more here just for your information. You don't need to memorize that. Pharmacy is going to take care of that on our end, but it's just there for you to know about. But we do dose it based on chronic versus acute. So the standard infusion is given over 30 minutes. It's important to remember we don't need to shake this medication, which unfortunately means we cannot tube it. So pharmacy is going to bring it to you guys. But if a patient is in cardiac arrest, we can give it IV push. So obviously we want to monitor EKG changes, potassium levels, blood pressure, and temperature. So for our case question, we have a 75-year-old male who's brought into the emergency department by his daughter. She said he seems a little more confused than normal. He can't see as well. He's vomited twice this morning. He has a past medical history of AFib, heart failure, hypertension, and hyperlipidemia. He currently takes the following medications: metoprolol, atorvastatin, digoxin, losartan, spironolactone, and aspirin. His blood pressure is 130/70. His heart rate's 115. His serum creatinine is elevated at 2.2, and his potassium is elevated at 5.7. Which of the following medications is likely causing a possible toxicity? Good, so it's going to be digoxin. So metoprolol, we would see more of a low blood pressure and a low heart rate. Atorvastatin, these vitals don't really apply. And then spironolactone, I guess you could see an elevated serum creatinine or potassium, but we didn't really talk about that drug today. Which of the following medications will need to be hand delivered by the pharmacy? All right, so hand delivered, we're gonna have to bring DigiFab because we can't shake it, so we can't tube it. Esmolol is not in the Omnicells, but we can tube it to you guys. And then the others we can send to you guys as well, but we need to physically bring it, the DigiFab, to you all. And thank you, Kristen, for answering the question about what the HealthPlex has, if they have DigiFab or not. So if you didn't see, she said the HealthPlex has a minimum of 6 vials of DigiFab, which is the amount needed for chronic toxicity. And then just as a recap really quick, so we talked about these 3 drugs and like the signs and symptoms to kind of differentiate the 3. So for calcium channel blockers, you're going to see more hyperglycemia. With beta blockers, you're going to see more hypoglycemia. And with digoxin, you're going to see more GI symptoms in acute or chronic, but more in acute. And then with the chronic, you're going to see more confusion. All right, so that was a lot of information. Do you guys have any questions this morning?
This is Patricia. I have a couple of questions. One on the amiodarone, when they're saying it's not for pregnancy, but I'm assuming if someone is pregnant and in a full arrest, we would use it anyways, right?
Yeah, so in some situations like benefit versus risk, but in general, that's not going to be our go-to drug for a patient who's pregnant.
And then second, can you explain why we are giving with the calcium channel blocker overdose? You typically are saying you have hyperglycemia. So why is the treatment for that insulin?
No, glucagon. Why do we give glucagon for the hyperglycemia with that?
Let's go back. So the glucagon is more to help with like the heart rate and the blood pressure, which is a little confusing, but it's not specifically for the, we're not treating sugars. We're trying to get the heart rate and the blood pressure up. That's why. That's a good question though, because it is confusing.
Okay, so then basically how, in a basic way, how is insulin bringing the blood pressure up then?
So specifically insulin, I made notes for these because it's kind of confusing and a little different. So specifically, it could increase the inotropy in the heart, which is going to increase contractility. It also can help with the intracellular glucose transport, and which ultimately can help improve the vascular dilation as well.
Hi, I just have a question. This was really helpful, first of all, so thank you so much for going through everything. Is it possible to get this, maybe not all of it, but especially like where you laid out the drugs and like most of the slides, like can we get those printed out and put up in our med room? Or like that, I just think that would be really helpful to have those bullet points because those are exactly what we need to know.
Yeah, absolutely. And then for those of you who have help at HealthFlex, for the first half of the presentation, I do have that for HealthFlex specific, what you have in your Omnicell and what you do not. So yeah, we can get those to you guys.
That's awesome, even better. Thank you so much.
You're welcome.
And Ashley, if you send me both of those slide decks, I can put that on Canvas as well, so that way staff can reference them. But to Emily's point, I think that is great, just having some of those quick reminders in our med room. I think that would be really helpful, that in the moment when you need that information. But we could definitely put it on Canvas as well, because we have a HealthFlex Canvas, and then we also have an Alex ED Canvas. So we can put both of those on there.
Okay, I'll send them to you.
Any other questions for Ashley?
No, thank you, Ashley, very much.
Thank you all for coming this morning. I hope this was helpful and something you guys can use in your daily practice.
Yeah, thank you so much, Ashley. It was great information. We really appreciate you presenting today. I think it covered so much information, and it's nice to hear the why behind things, not just hear the facts, but understanding like the pharmacokinetics behind it, I think is really helpful. So thank you for presenting. And like we said, we will make these slides available. We also recorded the presentation today, so we'll also put that on Canvas. So if you guys want to review it, and then for anybody that didn't have it, have a chance to be able to be on this Zoom, they'll have that opportunity to view it as well. And like we said at the beginning, if you would like that contact hour, you just need to complete the survey evaluation. It asks some basic questions and information there. If for some reason, if you're on your phone and you can't access this, just let me know, I can send it to you. But if you all could do the survey now, it takes literally, I think, 3 or 4 minutes, and then that'll allow us to give you award that contact hour as well. And this education is being paid as well. So I appreciate our leadership for paying for the education too. So you can fill out an exception form as well. So we'll leave this slide up here for a few minutes.
I could try to put the link to in the chat box.
Oh, that would be helpful if you could. See, I might be able to do that too.
There we go. So that's there if you guys want to click on it.
Oh, great. Thank you, Ashley. Yeah, that link should be active. You guys should just click on it and it'll take you right to the survey. And Emily, I saw your note in the chat. Were you able to make that link work? And if not,
Yes, Jenny, I did. I'm doing it right now, but I'm
great. Okay, no problem.
toggling between things. So
Gotcha, no
yeah,
problem.
thank you so much. This was awesome. So I
Great.
appreciate it.
No problem. And once you guys are done with the survey, you guys are free to go. And I'm going to go ahead and stop recording now.